name is Dr. Geeta Ganesh, and the title of my presentation is Choosing the Right Disease-Modifying Therapy for You. I have no financial disclosures. This presentation has several objectives: to discuss the timeline for FDA-approved disease-modifying therapies in the U.S., identify the factors used to select a disease-modifying therapy, discuss how disease-modifying therapies are grouped in terms of efficacy, review how a neurologist decides when it is time to change medications, and define the term shared decision-making. I'm going to start off by asking, how many of you remember the lottery? I'm not talking about your state lottery. I'm referring to the lottery created by the first FDA-approved disease-modifying therapy, interferon beta-1b, also called betaseron. This medication was approved in 1993. As stated in the pharma letter, the distribution of the product was controlled through a computer lottery, where each patient was assigned a number. This lottery was created because the manufacturer estimated it only had enough of a supply to treat between 12,000 and 20,000 patients in the first year. Close to 80% of patients were unable to obtain this drug immediately after it was released to market. It is hard to believe that access was so limited in the early days of MS medications. We certainly have come a long way since the first disease-modifying therapy was approved in 1993, and over the years we've learned both good and bad outcomes from these medications. Natalizumab, also called Tysabri, was first approved in 2004. Following several cases of a fatal brain infection called progressive multifocal leukoencephalopathy, PML, it was voluntarily removed from the market. The manufacturer returned natalizumab to market in 2006 under a special prescribing program. The first oral medication, fingolimod, was approved in the U.S. in 2010. In 2018, this medication became the first FDA-approved medication for children and adolescents with MS. Ocrevus, also called ocrelizumab, became the first FDA-approved medication for primary progressive MS in 2017. As of September 2021, there are 23 FDA-approved disease-modifying therapies for various types of MS. It's amazing that we have so many medications now, but it's just not possible to offer all of these disease-modifying therapies to every patient. It's not realistic for any MS specialist to go through the mechanism of action, monitoring, and side effects of every medication at a clinic visit. Furthermore, some medications may not even be an option for a patient. Potential barriers for patients include many factors such as method of administration, side effect profile, insurance requirements, medical comorbidities, and PML risk. For this reason, a one-size-fits-all approach to treatment isn't effective for every patient. Many neurologists narrow choices for a particular patient using aspects of precision medicine. Precision medicine takes into account an individual's genes, environment, and lifestyle to develop a treatment plan. This allows us to tailor a treatment to subgroups of patients. Many people use the term to refer to using genetic, molecular, or cellular analyses to find an optimal treatment. There are few commercially available examples of using blood, saliva, or other fluids to make treatment decisions in MS, but the term can still be applied when looking at a patient's environment and lifestyle to make a plan. Some clinicians may use the term personalized medicine instead of precision medicine when it comes to discussing treatments with you, but many people consider these terms interchangeable. This is just a small list of some of the factors a clinician takes into account when narrowing down options for you. Your disease course plays a big role. A patient with primary progressive MS, for example, may be offered a narrower set of options compared to someone with a relapsing form of MS. Recall that ocrelizumab is the only FDA-approved medication for primary progressive MS. When determining the efficacy of a disease-modifying therapy for a patient, some neurologists will determine if a patient still has an active form. Your age is another factor. Recall that fingolimod is the only FDA-approved medication for children and adolescents. The level of aggressiveness of your disease course should also be considered. Characteristics that have been associated with greater disability include multiple simultaneously enhancing lesions on one scan, poor recovery from relapses, more than one relapse per year, age at onset less than 35 years, brainstem or spinal cord involvement. Other characteristics that have been associated with greater disability over time include male gender and being African American. Many neurologists will choose a higher efficacy disease-modifying therapy for patients with potentially aggressive disease to limit greater disability later on in life. If you are planning to have a child, certain medications may not be offered to you or be considered only if you family plan at certain times. These general recommendations are based on pregnancy registries. An example of one medication that might be considered for a patient who is pregnant is glatiramer acetate. Based on the outcome of thousands of pregnancies on glatiramer acetate, the medication is considered safe. Your other medical conditions may also play a role in what medication options are given to you. A patient's cardiac history, infection history, and cancer history are examples of medical problems that can limit your choices. Preferences for a method of administration can limit options as well. As of the timing of this presentation, there are 9 self-injectables, 10 oral medications, and 4 intravenous infusions. This list includes generic medications and Novantrone. A person's history of adherence to medications might be considered. Not everyone is great at taking a daily medication. It may be easier to consider a treatment that has less frequent administrations, such as cladribine, alemtuzumab, ofatumumab, or ocrelizumab. A patient's JCV antibody status can affect whether he or she is placed on natalizumab. Tests to determine neutralizing antibodies to interferons or natalizumab are available and can limit options if they are positive. Finally, one of the most frustrating factors in options available to a patient includes his or her insurance. Some insurance plans require a patient to have failed certain medications before escalation of therapy can occur. As you can see, there are many decision points that help a clinician narrow options for each patient. To fully discuss all of these points would require separate presentations. A major criticism of the step therapy approach enforced by insurance companies is that patients have to endure exacerbations on certain medications before attempting a medication with a higher ability to reduce the annualized relapse rate. Several cohort studies and clinical trials are currently looking at 2 approaches in deciding therapies: escalation of therapy versus early use of highly effective therapies. In the escalation of therapy approach, the neurologist chooses from a set of treatments that often fall under the categories of first-line, traditional, or standard. Many of these treatments were among the first to be approved by the FDA. They are often associated with a lower reduction in annual relapse rates. They are often associated with less immune system suppression or less side effects, but this description does not apply to all of them. If a patient has clinical or radiological breakthrough on these medications, they are then escalated to a treatment with a higher efficacy, which are often associated with a higher reduction in annual relapse rates. The list on this slide could certainly be debated for hours. In general, lower efficacy medications are considered the interferons, glatiramer acetate, and teriflunomide. Some clinicians consider the fumarates, such as dimethylfumarate and diroximel fumarate, and the sphingosine 1 phosphate receptor modulators, such as fingolimod and zanisamod, to be moderate in terms of efficacy. The higher efficacy treatments are natalizumab, alemtuzumab, cladribine, and the B-cell therapies, ocrelizumab, ofatumumab, and rituximab. A discussion of each of these medications goes beyond the scope of this presentation. The second approach involves initiating a highly effective therapy earlier in someone's disease course. These treatments, which were listed on the previous slide, are sometimes called aggressive or intensive therapies. They are often associated with a greater degree of immune suppression. They sometimes are associated with more side effects, such as raising a person's liver enzymes. They have a greater association with malignancy, and some can be associated with a greater chance of developing other autoimmune diseases. Despite these issues, it is possible that starting these therapies early can lead to less disability later in life. Smaller cohort studies have suggested greater benefit to starting aggressive therapies earlier in terms of disability over time. 2 prospective clinical trials are currently ongoing. The TREAT-MS trial is a randomized controlled trial in which patients are randomized to one of 2 groups, a group receiving aggressive therapy or a group receiving standard therapies. The primary outcome is long-term disability. The secondary outcome are patient-reported disability, fatigue, and health-related quality of life. DELIVER-MS is also a randomized controlled trial and observational study. Participants are randomly assigned to either standard therapy or aggressive therapy. The primary outcome is brain volume loss from baseline to 36 months. The secondary outcomes are brain volume loss from month 6 to month 36, patient reports of symptoms, quality of life, satisfaction with treatment, and side effects. Once you are on your disease-modifying therapy, you may wonder what factors will lead to switching therapy. An obvious factor that suggests it's time to move to a different medication are side effects. Some patients on interferons, for example, can't tolerate the flu-like symptoms that occur with each injection. Another factor is the intolerance to the method of administration. Not everyone can tolerate a self-injection. Severe lab abnormalities, such as too low of a white blood cell count or liver enzymes that are too high, may also lead to discontinuation of your medication. For those on natalizumab, the value of your JCV index may lead to stopping therapy, especially when the risk of PML is too high. The concept of no evidence or minimal evidence of disease activity can also drive decisions on when to change therapies. We will discuss these important concepts in the next slides. No evidence of disease activity is often abbreviated NEDA. Another term that has been used is freedom from disease activity. It is increasingly being used as an endpoint in clinical trials for MS therapies. It is also used by neurologists to provide parameters for when to change medications. NEDA-3 is defined using 3 items: no new radiological activity in the form of new or enlarging T2 lesions and no T1 gadolinium-enhancing lesions, no progression in disability, and no clinical relapses. If a patient experiences a change in these parameters, it may signal that they should be moved to a higher efficacy medication. NEDA-4, a newer goal in clinical trials, includes measures of brain atrophy and cognitive measurements. Using NEDA in real-world settings is debatable. It could lead to lower levels of disability in the future, but it may not be easy to implement in some clinical settings. It is also uncertain if all 3 parameters should be weighted equally in NEDA-3. NEDA-4 may be difficult to achieve as not all MRI scanners measure atrophy and certain cognitive testing is not readily available everywhere. Minimal evidence of disease activity is an older approach to determining when to change medications. It defines a minimal amount of disease activity during treatment that can be tolerated without exposing patients to long-term disability. This term is not well defined, but some use the following parameters: no more than 2 minor clinical relapses over a 2-year period, no more than 2 new lesions over a 2-year period, or no more than 1 major clinical relapse. Many clinicians still follow MEDA guidelines because some studies suggest that minimal clinical or MRI activity may not be linked with worse outcomes. This method may spare a patient the degree of immune suppression or side effects from aggressive medications. At this time, there is no consensus on whether NEDA or MEDA should be the standard of care for treatment decisions. Regardless of whether NEDA or MEDA are being used, many neurologists want their patients to play an active role in deciding on a treatment. In shared decision-making, the neurologist guides a patient by educating him or her on the disease. A focused set of therapies are offered based on multiple factors, such as environment and lifestyle. The clinician then educates the patient on mechanism of action, side effects, and monitoring, and addresses the patient's concerns or questions. After satisfactory discussion, a patient can then make an informed decision on his or her treatment. With each visit, the clinician provides ongoing education on that treatment, particularly any updates regarding monitoring. Time often prevents the complicated discussions and shared decision-making. Nurse navigators, pharmacists, and advanced practice providers can help with this ongoing discussion, making them a valuable part of a comprehensive MS center. Thank you for listening to this presentation. It's hard to believe we've come a long way from one disease-modifying therapy with a lottery to so many options. It's easy to get lost in the forest if you try to explore options on your own. It's always important to talk to your neurologist if you have questions or concerns about your treatment plan. Thank you.